Omar is always trying to help others, and I think these series are very, very important to spread knowledge and to give the basics of whatever in pediatric cardiology. I just want to say that fetal cardiology is now and have been a subspecialty of the general pediatrics. So if you want to be a fetal cardiologist, you have to study fetal cardiology. There's one message, because you will learn more. You will give a message which is complete when you diagnose cases and you can treat. Looking at the background of my screen, this is the Congenital Heart Academy under Washington, D.C. Children's Hospital, and we are running almost a monthly webinar on fetal cardiology for the past 3 years. We have now 40 webinars, so you can learn all the syllabus of fetal hearts from world eminent perinatal and fetal cardiologists. And the series is available online under the fetal series, not just fetal, the fetal series, and you can watch and enjoy, and later on, if you like, you can ask me questions. Today, I'm going to talk about the indications of a fetal echo, because this is very important. I've been working now on fetal echoes in Saudi Arabia and the Middle East for the past 15 years, and we don't get referrals unless you know what you are referring. So this is very important that we understand who is the candidate for fetal echo. I think I have to go to the next slide. So why it's not letting me?
Start projection, دكتورة. اضغطي projection.
أيوة. So I'm going to give you a short example of how to understand the indications. Done many years back. Done a short research at the King Abdulaziz University Hospital, and we've updated this project later on. But I want to say cardiac abnormalities are frequently not detected by routine ultrasound screening examination. So who is doing the echoes? Who is doing the ultrasound? So most of the people in our country, there are two systems, American system and the British system. So either the radiographers is screening, or the primary care physician is screening, or the obstetrician is screening. So most of the worldwide, the detection rate of fetal conditions, heart conditions, is around 40%, which is very rare, very little. I must say it's not very good. 40%, it means that to detect antenatally the heart anomalies, you are only successful in 40%. In the best centers, now it's 50%. In our area, it was 25%. So why? Because we do not refer, or we do not understand when to refer, okay? Now, fetal cardiography is very important, but it's only highly specialized field, and you need special training. So what people will learn is the basics. What we ask sonographers, primary care physicians, obstetricians, fellows, and even sometimes our pediatric cardiologists who are just starting their career, to refer the cases on the least suspicion, and also to make sure that you have a normal 4-chamber view. The most important is the 4-chamber view. It's not easy to get a proper 4-chamber view. And if you can, the outflow tracts. And if you're really good, you can do the coarctation, the arch. Okay. Now, so fetal hearts and indications is fetal arrhythmias, abnormal 4-chamber, family history. This is from the guidelines. Family history of congenital heart disease. It means that the mother has congenital heart disease, congenital, not acquired, not acquired mild stenosis, secondary to rheumatic heart disease. Congenital, she was born, she has tetralogy of Fallot, she has VSD, and even the father. You have to ask the father, because fetus is a product of the mother and the father. Okay, so family history, and she has a baby with congenital heart disease. She has we don't really take syndromes as part of the family history, because most of the time syndromes, they come like Down syndrome, That's not um, all abnormality, not really uh, congenital. Congenital heart disease in the young people is part of uh, itself. Now, maternal diabetes is very, very important in Saudi Arabia, and SLE is very important as well. So maternal diabetes, whether it is gestational or non-gestational, the guidelines would say gestational, and nowadays they change them with any diabetes because preconception there is abnormalities in the fetus itself. Okay, and systemic lupus, we all know that we're worried about heart block. The heart block is very important, so that we know that if the fetus has heart block, and usually it's the heart block you get it would be diagnosed by CTG of bradycardia, and then you would refer to or perinatal cardiologist. You would do Doppler, and you would diagnose it as a complete heart block time. Now, fetal exposure to teratogen is very important. Now, the common teratogens now is when the mother is psychotic and she is on certain antidepressants like lithium. Sometimes certain types of depression, you cannot stop the medication. And if mothers sometimes stop the medication to get pregnant, and this causes harm to the mother, which you don't want that. So you have to plan it. So the mother has to plan it. It's really tough in our areas in the Middle East unless the mother is really educated and the couple, they know how to plan to get pregnant and so on. So but exposure to teratogens, sometimes unknown teratogens, we don't really know. And I would just say that it has been mentioned many times that the COVID vaccine has increased the incidence of congenital heart in the fetuses. And we couldn't prove it, but personally, I've seen patients coming by themselves for fetal heart scanning because they are worried that it could be a coincidence, it could be cause and effect, don't know. Now, fetal karyotype abnormality, as we say, that trisomy 13, 16, and 18, they have heart diseases most of the time. And for those who are sitting exam, most of the karyotype abnormalities have heart disease, most of them. Now, other fetal system abnormalities, we've been preaching that for our colleagues in the obstetrics. If you have a fetus with kidney problems, refer for heart scanning. If you have a fetus with brain problem, refer for heart scanning. If you have a fetus with spine problems, refer for heart scanning, because once you see a defect in the fetus, look for other defects, and vice versa. If I have abnormalities in the heart and the lady did not go through the anomaly scan, I have to refer her back because we are so much connected. The fetus is one system. Now, nowadays, it's up to 40%. So the low detection rate, why? It's because of the machines, it's because of the training, it's because of the lack of referrals, it's because of we don't know when to refer, and we don't know what we're looking at. Many times in the OB clinic or on the sonography clinic, they have to scan 30 patients per clinic, and this is impossible to detect heart because the heart is it's like a dime size, and you have to really spend time to get a 4-chamber view. So the number of cases to be scanned has to be sort of organized so that however the operator will have time to look at. Not even like for me, been doing it for years and years. For the first time scan, it's 45 minutes standard worldwide. So you have to really spend time. And if you're screening, you don't have to do 45 minutes for the heart, but you have to have enough time to scan the patients, because an anomaly scan, you're scanning the whole. Now, in Saudi Arabia, we have a lot of good colleagues who are doing fetal heart scanning. And as I said, there is a difference between pediatric cardiologists and fetal cardiologists. There is a difference, but most pediatric cardiologists can do good heart scanning. But the fetal cardiologists, those who have a fellowship in fetal cardiology, extra fellowship, know how to do the whole package, which means that history, scanning, management, planning, and treatment. So this is the difference. But to know that this baby has tetralogy of Fallot, that's not the end of the story. Tetralogy of Fallot means you have to talk to the mother, you have to plan, you have to refer in utero, you have to know which center she's going to, and you have to know the operation is going to be in which place, and we transfer in utero, and then we also check for genes in the fetus and genes in the parent, and it's a long story. So I'm not going to go through this a lot, but what we see here is that we've done a retrospective study looking at the primary indications for fetal echo among pregnant women who underwent prenatal sonographic examination. Look at this is a retrospective study. It means that you just go to the files and look at them and see what was the prenatal, and then you look at the postnatal. So you have to compare pre and post. It's not saying, oh, I've diagnosed a tetralogy of Fallot, maybe it's more than that postnatally, or I've diagnosed VSD antenatally and it comes as the tetralogy of Fallot postnatally, or I have diagnosed VSD and it ended up with VSD with coarctation postnatally. So you have to compare pre and post. So we're trying in this very quick test study to determine the primary indications of congenital heart disease, and it was a retrospective study, very old, and we looked at the pregnant ladies over 1 year period, and they were examined by one fetal cardiologist, which is me, and at that time NT was not included as an NT, was not available in the King Abdul the maternal fetal medicines were not doing that either. They didn't get the first trimester referrals or for other reasons. Okay, now what we did in this study, we looked at why those babies or those fetuses were referred, and we studied the fetal echoes pre and postnatal. Now, 60 pregnant ladies have been referred for fetal echo in the same institute of others were. And the most common primary indication was abnormal four-chambers view. But they say it was abnormal heart. So probably, and if they write more details, it's abnormal four-chamber view. And so most of the time it was like 35% abnormal four-chamber view. And in 19 of the 21 cases, congenital heart disease has been confirmed prenatally and postnatally. This is a good outcome because the operator is trained to do this. But in other places, maybe there is no fetal cardiologist. They don't have in the institution, or they did not refer, or it was such a long story to refer, so the mother delivered before the referral. She's referred to the fetal cardiologist or pediatric. And also, it's a system that you have to look at when the mother was seen first time and then second time, and when she was referred, and was she referred on the right time, and did the mother herself come back? Because some mothers, they are so tired with the pregnancy, they have a big house to look after, and they're not really interested in coming to the hospital just for scanning. And she's happy, she's saying, "I will give us a good baby." Good, but Islamically, and have to really tie the camel where you say Allah will give us a baby. So they confirmed, and find that common common here, and then family history of congenital heart disease. We tend to miss that if we don't take proper history. What I see is that the mother comes, the pregnant lady comes to the clinic, there are 10 pregnant ladies waiting outside. Nobody asks her why you are coming to the scan. The scan is only 50% of the story. You have to talk to her first, greet her, tell her you're okay, because pregnant mothers really are so anxious when they come to for a scan, whatever type of scan, because they're so worried that the baby will be abnormal. So while talking to the mother, you take history, why you're here, and we have a questionnaire that they have to read and sign. So why you're here, and who referred you, and all that. This is very important. And you know if she's diabetic or not diabetic. Sometimes she's referred for heart, like last week. I had an IVF case. I had to scan the mother because of oligohydramnios. Oligohydramnios means there's a very little water around the fetus. And of course, once you have anything abnormal, you have to check the heart. And while she's in the clinic, we're taking her vital signs. We find that her diastolic is around 100. And so she is hypertensive. And I asked her, "Are you hypertensive?" And she said, "Well, I was told that it was high, uh, uh, and it was. I wasn't 2 days back." And then we asked her, the second question is 22 weeks, and asked her, "Did you have a sugar scan?" Because this is very important. Because when I was scanning, I found that the heart was thick, and this is part of hypertrophy secondary to the diabetes mellitus. So talking to the mother, you've known that she's hypertensive. This could explain a little bit why there's oligohydramnios, because there's placenta perfusion is a little bit limited, and also you wanted to treat her hypertension. You have to check for the urine for the albumin and proteinuria and blah blah blah. So just taking vital signs in our clinic is very important. As we do for children, we take the pulse oximeter and blood pressure. It's very important because sometimes mothers don't know that the baby is hypoxic and he's blue. So talking and taking vital signs is very important, and this is part of 50% success. Is you don't sometimes you are not very good in scanning, but you're good in taking history. At least you know what to tell the mother and where to refer. And don't be shy to bring her back for scanning. So the commonest thing that we found here was the AVSD, and out of anyone. And this is probably the easiest diagnosis to get. You just find a hole in the atrium, hole in the atrial septum, and hole in the ventricular septum. That the offsetting of both valves are the same. So you think this is AV canal. Aortic stenosis is not easy to find in utero because you don't find the gradient that you see postnatal. Antenatal, the pressures are different. Tetralogy of Fallot is good, and it's easy in good hands. Sometimes it's just it's reported as VSD, while in fact it's a tetralogy. But also we have to be fair and say that it's a progressive lesion in the heart. So she could be scanned at 18 weeks, and there is no valve stenosis at that time. It's only the VSD and the overriding of the aorta. So you have to bring them back. I always like to bring my patients back. And I want to make sure, because it's a progressive disease, whatever you see, pulmonary stenosis at 20 weeks could end up at 35 weeks with pulmonary atresia. So the whole valve could be closed. Now, the hypoplast is very easy to diagnose because you only see one ventricle out of the two. It doesn't matter if you don't know which is right and which is left, but if you find it's hypoplast, the outcome is the same 3 operations, and this is the normal, whether right or left. But also there are tiny details that you have to know if you're a professional counselor to know more about the outcome and look more about the arch, the size, the PSD, the ventricular size, if there is endocardial fibrinostosis or not. And then you find rhabdomyomas. It's a mass in the heart. I'll show you at the end of this some views, some videos. It's a mass. What you see, tumor in the heart, the rhabdo is tumor, and it's very easy to see and very easy to diagnose. Usually multiple tumors, and usually transposition. You can miss transposition if you really don't do proper, and you see the crossing of the outflow tracts, and you do the three vessel view. Transposition could be missed, and a lot of people have been burned by transposition. Transposition intact ventricular septum, I mean. And so this is the tetralogy of Fallot and the overriding aorta, and this is the VSD. It's just a still image, and this is the rhabdomyoma, where you see a lot and this is a 3D picture of the rhabdo. You see a lot of tumors in the LV here, and if you are really if you focus more, you find a mass obstructing the outflow tract here. This is in 3D, but if you do 2D, you find different story. Now, the VSD is easy to diagnose, but it depends on the position. I'm sorry, most of the videos are not working, but I'll show you at the end more videos outside this scope. So here, and you have to look, and you have to look at the interventricular septum, and if you see a crossing of the septum, and this is by color, this is. But you have really more views because it could be a drop off if there's a certain angle where you're doing the cut. And this is 3D also, where you try and see a crossing across it. 3D means that you're looking at the heart at X, Y, and Z planes, and it's like a pyramid. So you really look more into the depth of the size of the ventricles. I'll show you at the end. And then, of course, Epstein anomaly. Last week I have Epstein anomaly. One of the worst diagnoses that you have. Epstein is diagnosed when you have the valve, the tricuspid valve is not in its position. It's going more towards the apex of the right ventricle, and it's a spectrum. And usually, most of the time, it's a poor prognosis, especially if there's cardiomegaly and a lot of atrialization of ventricle. Not a disease that you like to anticipate. This lady, we saw her last week, also came late, told that at third month that there's, sorry, at 20 weeks, them tell her, and so she was tired, she didn't come, but she came at 30, with her, and there was a custody from circular shunt in utero, so the prognosis is poor. And we've done her Dopplers, we find that in the Doppler there's something called absent diastolic flow in the uterine artery. It means that the baby's going to die in utero. So the question here, are we going to do cesarean for this mother? Of course not. Of course not. The baby will not make it. Anyhow, to pass through the birth canal. Okay, deliver by cesarean, but should we really expose the mother to a cesarean for a baby that's going to die? So we made a conference call, and the obstetrician said, no. This lady should not have a section. This lady should deliver, and if she does not deliver, if we don't induce her delivery, the fetus is going to die either in or out. So the consensus here is that she came late, and very bad diagnosis, of course. Sometimes we can treat antenatally the heart failure, but she came late, and then we always talk as a team. The patient is not yours. You are a consulted doctor, so you share the fetus with the original maternal fetal medicine or obstetrician, and go back to them, and they listen to you say, I don't think that the heart will make it for birth canal. So they take your word and they say, okay, probably do cesarean. But in this case, they all agreed, more than one, that it's not worth cutting the mother, and she's only 20 years old, and this is her second pregnancy. So as I said, up to 2119, which is detection rate is very good, had congenital heart disease. Okay. Now, our study showed at that time common primary indication, which is the abnormal heart, which is still the case. But now, after talking to people, talking in radio and TV and making a lot of lectures, we are getting a lot of diabetics, which is very important, because diabetes really can affect the heart, can cause complex heart disease, can affect the size of the fetus, of course, and make it bigger and make the heart also big. And it's important nowadays worldwide. People are really sort of scanning all diabetics. Now, some of our colleagues in the MFM would say, no, I would refer only the diabetics that are gestational diabetes, means from pregnancy. But why? So indications nowadays is both the type 1 or 2 and the GDM. So you have to do the advised routine fetal scan. If you're interested, this is the book that I authored with two of my mentors, Lisa Homburger and James Yuta. It's available, it's out of print in Mosby, but it's available in Amazon. You can buy it. And it's 36 chapters with 36 problem-based. It's the only problem-based book worldwide that talks about what you see in the clinic, how you deal with it, and the outcome. Um, try and make it as simple as possible. So there are maternal, fetal, and familial. So this is free from the mother about her pregnancy, about her medication, about if she has congenital. It's IVF. Like this lady, she didn't tell me it was an IVF, and she said I was referred to you because I've already had Ramnes. How many babies and children you have? She said two. How old? 9 and 11. Nice, but it's a long time now. After 9 years, you want to become pregnant. She said, yes, this is an IVF. So now we change gears. It's not just if you stayed 8 years without pregnancy. You ask if there's infertility or not. You ask, and then you know it's IVF, so it's a high risk, very high risk pregnancy. And with IVF, I always keep saying that IVF, it's a fetus that will have for sure higher incidence of congenital anomalies in general. Not that much, but it is there. So we try also to tell our maternal fetal medicine colleagues to repair all or IVFs for screening for heart defects, but they find it very sensitive because the mother had just a baby and they're very happy to have a fetus after maybe 2 or 3 trials of IVF, and they don't want to tell her you have to go at 14 weeks with scan starting from 14 weeks to check the heart. So also, we are also proposing that most of the IVFs will have to come because an IVF is a baby that is done outside the uterus, and it's in a place, it's in a tube or a test tube baby, whatever, or a petri dish or whatever, and then it goes into the milieu, which is the uterus. So you expected there's something abnormal in it. So, and I find it very interesting that many young ladies now want to have IVF just to get 2 babies and end the story. And I'm also preaching that IVF should be for the indications of IVF, not really for being happy and you want to get 2 babies and then stop getting pregnant. It doesn't work like that. Allah made it for those who need it. So the maternal indications and the fetal indications, and there's familial. Now, sorry, back one slide. Okay. The fetal indications is like extracardiac fetal arrhythmias, chromosomal structure, heart defect, non-immune heart. It's very, very, by the way, very, because it's correlated with the higher end back the neck, the higher the incidence. Direct correlations. NT is 6 instead of 5. There is a higher incidence. Now, going back to the previous start of the hearing, as we said, diabetes and you have time that's coming back in our society. And I had a scandal uh, uh, something, and she didn't know that she was pregnant. So now anybody who's getting the indications, trying to treat their pimples in the face with vitamin A tablets or things like that, they have to. Most of our doctors, the dermatologists, tell them do not get pregnant for 3 months at least after you stop the medication. So she was pregnant while she is on the medication. So the chances of having anomalies in the baby is 60 to 70%. So she went, and I just want to share the stories with that. Her dermatologist said the baby has, and she was only, I think at that time, like 20 weeks. He didn't do fetal echo, didn't go until, so somebody else told her, I think Wizrat al-Siha, we cannot allow this to happen until you have an anomaly scan. So she had an anomaly scan, and alhamdulillah, the baby was okay. Now she came for me for the heart, and the heart was okay. Now she was very lucky because I've seen a very deformed fetus. Well, she's also a Turkish mother, 19 years old. Took this medicine, and she continued to take it for the first 3 months of her pregnancy. This lady was very lucky. So medication. Now, maternal also antibodies, which is like SLE and other things. So the antibodies in the mother go to the fetus, and they think that the fetus is something they don't want. So they attack the fetus. This is what happens in SLE. They attack the conduction system in the heart. So antibodies are very important. And with SLE, if we detect early, we can actually stop the process of damage to the heart, i.e., we stop the damage to the conduction system, and the mother, the fetus could be saved if they come early. Now, familial indications, Mendelian syndromes, which is like a pattern of inheritance, which is autosomal dominant or recessive or X-linked. So these are Mendelian syndromes. Tuberous sclerosis, Noonan, DiGeorge, and Holt-Oram. DiGeorge is very, very, we don't see really DiGeorge. When we do the FISH for 22q, it's a spectrum vericardiofacial syndrome. And it's very important with the conotruncal anomalies. Holt-Oram, it's a VSD. Noonan syndrome, most of the time is the left heart. And tuberous sclerosis, I'll show you, which is usually in the Caucasian families in the Middle East. Paternal heart disease, we tend to forget the father. The father is very, very important. The paternal age is very important. It has not been proven to cause heart, but the older the father, probably the higher the incidence of anomaly. And some anomalies are related to the age of the father. Previously affected child. I'm getting mothers really because of a lot on TikTok and a lot on other Facebook and Twitter. When they come for scanning because she had a VSD baby or she had a hypoplus baby. I had 3 weeks back, I had a mother who had a complex heart disease in the first baby and had surgery. And then she came to me in the second baby and it was normal. And she came to me in the third baby. It's very abnormal, complex heart. So the recurrence risk is high. And the baby now it's at university is trying also first one single ventricle, and the third one was also another pattern of single. So this is very important that we talk to our patients. Now, this is from another hospital, let's say kids in Toronto, and this is more or less similar to what we found, a suspected cardiac defect on OB ultrasound. Well, OB ultrasound in America and North America, it's usually the OB that refer. And of course, we have our maternal fetal doctors who can scan the heart. So they have extra training in heart. And so we depend on them quite a lot for the referral. And usually it's very fine referral. When they refer, it's usually very serious. Now, extracardiac, we talk about the brain, the kidneys, the spine, whatever. So what are the indications? This is from our book that we co-authored, and we see the maternal, fetal, familial. You see the maternal diabetes and vaccine exposure, and also we have a maternal heart disease and metabolic disorders, and then for the teratogen exposure and so on. For the fetal, you have obstetric ultrasound in the heart and obstetric ultrasound suggesting abnormals outside the heart. The familiar, of course, a Mendelian and cardiomyopathy. Actually, I've seen a family of cardiomyopathy, and the mother was a nurse, and she was saying, when I told her the fetus has cardiomyopathy, means dilatation of the heart, and function was at that time normal. She said, he's like my other son. So, both are boys. I couldn't say it's an X-linked cardiomyopathy. It could be just a coincidence, but cardiomyopathy genes are very difficult to track, I was told by the geneticist. Now, we're just going for the fetal more and more. And when we do the fetal scan in the hands of a fetal cardiologist, as I always say, fetal cardiologist is different from pediatric cardiologist. I've done, like, say, 4 years extra training after pediatric cardiology in fetal cardiology, hemodynamics, and 3D, and so on. So if you want to do things properly, you have to study the heart. If you want to do VSD closure with a device, you cannot be just a general pediatric cardiologist. You have to have extra training in intervention. If you don't want to, I could read I could read cardiac MRI, but I'm not trained in cardiac MRI as a pediatric cardiologist, and so on. So better to really to improve the status of the cardiac services in our kingdom, we have really to be specific in what we do. You can do, but better not to do, and refer to the person who will give the patient 100% advice and 100% outcome. Okay. Now, so this is trying to summarize the arrhythmias, the pathology. Now, when I first started, nobody referred to hydrops, because hydrops that you have fluid, whether it's the heart or bronchitis, already non-immune hydrops or any type of hydrops will like it. And most of the time, if you just don't make the fetus. Now, um, uh, we help not stop, but slow down the process of heart failure. So the heart failure means the fetal heart fails to meet the requirements of the fetus, of the body, so it fails. So we try to give digoxin, we try to give, but high doses, it's really not an easy thing to do, and take consent, and at least to buy 1 week if the baby is okay. I mean, so high drops is not as bad as it used to be if diagnosed late in pregnancy. So I'll just show you that if you want to be successful in referring, you have to have a proper 4-chamber view. This is very important to check where the atria and where the ventricles and where the septum is. And of course, the difficulty in the heart of the fetus, we don't know situs, soletus, or situs, and first complex because the baby keeps moving and it's not easy. But at least if you see, at least you comment on the 4, really look at the 4-chamber, you find a lot. If you find that for example, that the septum is deficient, as a VSD, or the intra-air septum is deficient, there could be an ASD. We don't diagnose foramen ovale in utero because it's part of the normal physiology, okay? Very difficult to diagnose ASD secundum in utero. You can diagnose primum. And here, if you look at the valves here, the offsetting, so if the valve is going down here, this is not the LV, it's the RV, and so on. You can diagnose L transposition, and you can diagnose a lot from just from the 4-chamber view. And this is the hydrops I wanted to show you, that there is fluid around in the ascites, in the abdomen, and fluid around the heart. And I will show you a movie of that. So there are lots of, and this one, so here, we don't know why baby had hydrops. Okay, this heart looks okay. And so it could be secondary to anything as viruses, whatever. And this one, it was finger lab projections in the ventricles, and that has caused the hydrops. It's like a non-compaction in the fetus, and it's caused hydrops. So the hydrops, or a baby could have arrhythmia. So if you have a fast heart rate of 250 most of the time, you will fail. And failure means heart failure, means edema, means hydrops. If you have abnormal and just like heart block and whatever, it could also be a cause of the hydra. And well, she was self-referred to, and she said, "Unfortunately, I want to make sure that that I don't have a baby. I'm multigravida." And actually, it ended up to be. She came to me without herself, so she didn't know that the baby could be trisomy. So actually, once I saw this, which is a common AV valve and a VSD and a right and left, and so this is atrioventricular defect, and you have to check whether it's AV valve regurgitation or not. So I referred her for that colleague, maternal fetal medicine. They done NIPT, and the baby was down. Now, she was not happy with the result, but she was happy later on because she could arrange her life for the baby that's coming. And this is the breaking the news to the mothers. Usually they cry first time. I bring them second time and third time, and I try to make it easy. They don't understand the counseling for the first time. I have to counsel second and third. And also there could be a conflict between the couple later on, because if they have a previous baby who had a heart disease before, now they ask me who to blame, the mother or the father. Now in culture, usually the father would like to go and get married to another one. So, and when you tell them, look, I mean, congenital heart disease It's multifactorial. And then nowadays, we're proceeding with others to do genomes on most of the fetuses. And when it is positive, we do it on the parents. It's very important. The kingdom is really working hard on helping families, and genetics is worldwide. And we in our country have a good milieu for detection of the genes that cause multiple congenital heart anomalies. Okay, and this is using the 3D. Again, I'll show you those images working later on. And if you look here, and in the 2D, you did not see. I'll go back on this one. Here, you did not see asymmetry in the ventricles. You thought that both of them are already. It's a little bit small, but if you're really looking very deep. Now, if you do the 3D, you can see the asymmetry clearly here. Okay? You can see the asymmetry clearly. So once you see asymmetry in the ventricles, the counseling changes, because you have to look at the vessels coming out of this small ventricle. Sometimes there's not enough flow. The VSD is small, not enough flow to let the pulmonary artery grow. If this is the RV, if it is the LV, you have to look at the aorta coming out and the valve. And of course, once you look at the small, if it is asymmetrical, we call it unbalanced AV canal, you have to look at the arch, because it's all one spectrum, left heart, but the shown complex. Okay. Now here, when we do the unfolding, it's the gooseneck, like we see in cath lab, of the LV, and this is proof that this is an AV canal. Okay. Again, the book, if you're interested. And I just want to thank you for being with us, and I'd like to thank Omar for this beautiful invitation.